I wanted to start out in our lecture on cerebrovascular disease today by first telling you what we won't be going over in any detail at all, and that is really based on the content outline for Step 1 boards, which you can see here, the recent edition that after October 20, 2020, the emphasis is certainly on medical knowledge and diagnosis, but look at this in terms of management. And so I will be saying a few words about what we do for patients that have stroke, how we treat stroke, but that is just sort of for interest's sake. We won't be testing over management of stroke, but we do go into this a lot during the third year clerkship. And it's kind of a pity, actually, that we don't have time to go over this now, or that we choose not to go over it now, just because there are so many new things that we can do for patients that have had a stroke during the acute setting. It's actually quite exciting when I think back to 20 years ago, where options were very limited. So we'll be dividing the lecture into ischemic stroke, that'll be our biggest category, then hemorrhagic stroke, subarachnoid hemorrhage, and then finally cerebral venous thrombosis. This lecture has a lot of review information from our lecture on the cerebrovascular anatomy, the lecture on cortical neurology, neuro-ophthalmology. There really are not a lot of new things in this lecture, so I hope this will be an opportunity to bring together some of the previous material. So first on ischemic stroke. Patients that have had a stroke have acute focal neurologic deficits, and the deficits depend on what area of the brain is not getting enough blood flow, oxygenation. And I just want to highlight here two things. I think we've talked a lot about when someone has an acute problem in neurology, assume it is vascular until proven otherwise, but really could not overemphasize the importance of the fact that patients have focal deficits as a result of a stroke. What does that mean? Well, when someone comes in, let's say to the emergency room, and they're confused, but they don't have anything focal. And by focal, I mean a hemiplegia, an aphasia, a homonymous hemianopia. Those would all be very focal deficits. So just a confused patient, but their neurologic examination is otherwise normal, that is not at all likely to be a stroke. All right, so we're looking for something focal. And so the mechanism can be either thrombotic, blood vessel just became occluded, or embolic, so we can have a clot that travels from the heart or the carotid artery until it reaches a point where it can't go any further, or we can have a global hypoperfusion, and we'll give an example of what that looks like. It's really important that when we think about patients that have had a stroke, we want to divide it into anterior and posterior circulation. And the reason is, first of all, it's just very practical. When you're seeing someone in the emergency room, and usually it's fairly obvious if someone's had a stroke, they have a hemiplegia or something. Anterior versus posterior circulation will guide what we're going to do for that patient in terms of diagnostic testing and even treatment right in that emergent setting. So for example, if someone has had a posterior circulation stroke, well, let's not rush that patient off to look at the carotid arteries, right? That doesn't make any sense because it's posterior circulation. Also, our newer treatments where we can actually go in and extract the clot, and we can do that within 24 hours, or it needs to be done within 24 hours. That can be successful for anterior circulation strokes. So, understanding the anatomy, the neuroanatomy, and putting it in one of those two big categories is very important. Also, we want to determine if strokes are due to occlusion of large blood vessels like middle cerebral artery, posterior cerebral artery, anterior cerebral artery, or if it is due to a small vessel stroke. So again, our workup and also how we're going to treat those is different. All right, so I won't review all of the cerebrovascular anatomy with you again, so I just want to emphasize here that we want to know, is it anterior circulation, internal carotid, or is it posterior circulation, vertebral artery? Okay, and so again, here are the carotids. Of course, the middle cerebral artery is traveling through the sylvian fissure to supply lateral structures. The anterior cerebral arteries travel up here through the midline. And then, of course, we have our vertebro-basilar system here with the vertebral arteries and the basilar forming the posterior circulation. All right, so it would be a good exercise at the end of this lecture and a good way to kind of review really high-yield information for the final exam, to just sit down with a blank piece of paper and see, can you draw out the circle of Willis and all of the branches off of the circle of Willis, and imagine what deficits the patient is going to have with occlusion of different blood vessels, because we really will have gone over all of these here in this lecture, and in the neuro-ophthalmology lecture we talked about the ophthalmic artery. So we've referred to patients as vasculopathic patients if they have stroke risk factors. So this just summarizes, when we say someone is a vasculopath, we mean they have usually several of these. Okay, hypertension is the most common risk factor for a stroke, followed by diabetes, and then a constellation of others. Smokers, a little bit more common in men overall. Of course, we don't see strokes in younger individuals very often because you usually need to have had hypertension, diabetes, or a lipid problem for a number of years before you have a stroke. So dyslipidemia and obesity and a sedentary lifestyle. So just like when we talked about dementia, that exercise is one of the best things that you can do to try to lower the chance of that. Same thing here for stroke. So look at just all of these, I guess except for being a man, these are things that are completely risk factors that can be modified. So really more effort should go into trying to prevent strokes. It's great that we have treatments for patients that have had a stroke, but yet we also feel bad whenever that happens because usually it's something that could have been prevented. Now, when we have someone with a younger individual that's had a stroke, that should prime us a little bit for thinking about cardiac etiologies. And so a number of different heart rhythms, but in particular atrial fibrillation is a major risk factor for having a stroke. So this may be someone that doesn't have all of these factors up here, and atrial fibrillation can sometimes be difficult to detect because the atria is quivering, a clot forms on the wall, goes up to the brain. The patient comes in, because they've had a stroke, and then maybe they went out of atrial fibrillation. And so we sometimes need to do prolonged monitoring to detect that the patient is going in and out of atrial fibrillation. If someone has had a myocardial infarction, especially if it involves the lateral ventricle, just because that has the most muscle. So if you have a focal area of the lateral ventricle that isn't contracting normally, clots tend to form there, and the patient would be at a higher risk of stroke. And if we have a very low ejection fraction, the heart is just not pumping normally, again, that's someone at risk for stroke. So alcohol, there are some different things about alcohol, but an extreme excessive use of alcohol can be a risk factor. And remember, oral contraceptives, especially in women that have classic migraines, is a risk factor for stroke. So overall, at least 90% or more are caused by modifiable stroke risk factors. So if we have someone, a younger individual that has had a stroke, remember cardioembolic would be one possibility, but also if it's at all related to trauma, someone is in a car accident or something like that and they have a stroke, assume that is due to a dissection, either of the carotid artery, if it's an anterior circulation stroke, or of the vertebral artery, if it's a posterior circulation stroke. And then we would have rare conditions like a vasculitis. So patients with giant cell arteritis, for example, can have strokes in the brain. Or we can have a hypercoagulable state as well. So in a younger individual, we often will do a quite extensive workup to see if they may have one of these hypercoagulable stroke syndromes. So a TIA is a brief episode where an area of the brain doesn't get enough oxygen, blood flow, and patients have a focal deficit. The duration is almost always less than 5 minutes. Now, if you look up a definition of a TIA, it says less than 24 hours. But that is really a definition that came before the advent of MRI imaging. Because what happens is if you've had, let's say, a hemiplegia for 12 hours and then it finally resolved, in the olden days you'd do a CT, it's normal, you would call it a transient ischemic attack. But we now know with MRI imaging, which is so sensitive for detecting a stroke, that if you have a deficit that lasts for several hours and then resolves, well, then it probably was a stroke, but just, the patient got back to normal. And if the stroke is small, oxygen can be restored, it leaves a mark in the brain, but the patient is back to normal. So TIA is, we think of a duration of 5 minutes or less. So the one TIA syndrome that you really need to know is amaurosis fugax. And so this is a transient loss of vision in the eye that is almost always due to carotid artery pathology. And so this is painless visual loss. It's sort of like a fog, just gradually a mist covering the vision in one eye. It gets darker and darker, and then the patient is blind. That is sometimes called the curtain sign because the vision just slowly blacks out like a curtain being pulled down. And so if you hear that story, then that patient needs to have a carotid ultrasound because it's due to extracranial carotid artery disease. Emboli goes to the retina. And so if a patient has a significant narrowing there on carotid ultrasound, then they're probably a good candidate for a carotid endarterectomy, where a vascular surgeon goes in and can basically remove the area of stenosis. Now, all of the stroke syndromes that I'll be going over in this lecture can present as a transient ischemic attack. So someone may have a global aphasia, for example, with right-sided weakness. And after 5 minutes, they get back to normal. Well, you would be very concerned about that, right? Because if someone has a TIA, it means they are at risk for an impending stroke. So we need to do a workup and we need to treat that patient appropriately so they don't go on and have a stroke. So again, the 24-hour definition, I hope I explained that adequately. It's just a kind of a terminology. If someone has a longer lasting deficit and they recovered, well, they still probably had a stroke. And you can prove that by doing an MRI scan. So let's start with the anterior circulation. So here we have the internal carotid artery with an obvious narrowing. Okay, and so sometimes we will find a patient that has something like this, and if they had good collateral flow, other blood vessels are able to supply the area that's affected here. Patients may be asymptomatic, or they may have involvement of the ophthalmic artery, perhaps as an amaurosis fugax. The middle cerebral artery and the anterior cerebral artery come off of the internal carotid, so we might have an MCA stroke, or we may affect both the MCA and the ACA, which would be a really devastating stroke. And then remember, the anterocoroidal artery comes off the internal carotid, so we'll talk about that as well. All right, so here are the features that we can see with a middle cerebral artery stroke, whether it is right or left hemisphere. And so here is our motor and sensory strip. And recall that the homunculus here, the face and the arm, are located out laterally. So patients that have an MCA stroke that involves the precentral postcentral gyrus have a contralateral hemiparesis that is more the face and the arm. The leg fibers, which are up here medially, are supplied here in yellow by the anterior cerebral artery. Right? The optic radiations, that some of them loop through the temporal lobe, some go through the parietal lobe, but they are supplied by the middle cerebral artery back here. And so if our stroke extends to this area, the patients may have a contralateral homonymous hemianopsia. If it involves more of the temporal lobe fibers, they might have that pie in the sky deficit, or if it's the parietal lobe, they may have more of an inferior quadrantenopsia. And remember here that in the middle frontal gyrus, we have the frontal eye fields. And so patients may have a gaze preference, and I'll remind you here in just a couple of slides what that looks like. All right, so middle cerebral artery, it's motor and sensory, opposite side of the body. It's the frontal eye fields and the optic radiations, seen here by the dashed lines. Okay, and in just a minute we'll talk about left hemisphere where you will have the language areas involved. All right, so this shows you the middle cerebral artery supplying the lateral hemisphere. Now, if we have a more proximal occlusion, like of the carotid or the proximal portion of the middle cerebral artery, then you can affect the penetrating branches here, these lenticulostriate arteries that are supplying the internal capsule. And if that occurs, then the patient will also have significant leg involvement. So it will be face, arm, and leg, because you're getting the face and the arm out here, and in the internal capsule, you're getting the face, arm, and leg. All right, so a more proximal occlusion results in a more significant contralateral weakness and sensory loss. Okay, so we've been over all of this. I just wanted to remind you that if someone has a large middle cerebral artery stroke, this is what the visual field is going to look like. So when we see this, where we have kind of a dense, the opposite space is just lost, that usually is a middle cerebral artery stroke. Okay, again, if it's more parietal lobe fibers, it'll look like this. And if we just got the temporal lobe optic radiations, we'd get that pie in the sky visual field deficit. Okay, so if we get the frontal eye fields, recall that if we're looking at the left side of the brain, that wants to move your eyes to the right. Okay, so the eyes can't look to the right, they look to the left with a left MCA stroke. Okay, and if you affect the corticospinal tract here, you're going to get a contralateral hemiplegia. Okay, so as the patient looks at the screen here with a left MCA stroke, the eyes look to the left, the right side of the body is weak, so the eyes look away from the hemiplegia. Okay, or you can say the eyes look at the lesion, but I think it's just easier to remember whether the eyes look at or away from the hemiplegia. So if it's a dominant hemisphere stroke, usually left hemisphere, then if it's a massive stroke, the patient will have a global aphasia. If it's more posterior, they'll have a Wernicke's aphasia. And remember, the optic radiations are right by Wernicke's area. So patients that have a Wernicke's aphasia usually can't see anything off to the right side. Whereas with a Broca's aphasia, it's immediately adjacent to the precentral gyrus. So a patient with a Broca's aphasia almost always has a contralateral hemiplegia. Okay, and then remember, the high yield for boards in the real world, very rare, but if you were just to knock out the arcuate fasciculus, you'd have a patient with kind of a vague language problem, and the big clue here is that they are very poor at repeating sentences. Now, if our lesion is just a little further back, so we've got Wernicke's area mainly here, all right, but if you've got the stroke far posterior, back here around the angular gyrus, then this is when we get Gerstmann syndrome, which we've already talked about. But just for review, patients with a stroke here have right-left confusion, finger agnosia, acalculia, and agraphia. So just a quick way to assess for this is ask a patient, show me the index finger on your left hand, because that right away checks these first two. And then you could give a patient some simple math problems, ask them to draw a clock, something like that. So the lesion for Gerstmann's is primarily angular gyrus and the supramarginal gyrus to a lesser extent. So you need to be able to recognize on a CT or an MRI scan what a middle cerebral artery stroke looks like. And so this one is a bit more posterior. Okay, this would be the posterior cerebral artery distribution. This would be the anterior cerebral artery distribution. And so this patient has spared this more anterior portion. If we were just to outline the whole middle cerebral artery, it would look like this. Okay, so this is a more posterior middle cerebral artery stroke. This is the left side. So we would expect this patient to have a Wernicke's aphasia, and the optic radiations are looping right through here. So this patient is going to have a contralateral homonymous hemianopia. Recall that if we have a right MCA stroke, that now the patient has all these features of denial of illness, denial of the involved body parts that are involved in the stroke. They have a contralateral hemispatial neglect, so you ask them to draw a clock or something, and they don't put any details here on the left side. Okay, and then they may have extinction. Remember, that's where you touch the patient on the right and left side of their body in two different places at the same time, and the patient will have extinction of the left side of their body. So that's what we see with a right MCA stroke, and if you were asked to choose a lobe of the brain that's involved in that, it would be the parietal lobe. Here's a CT of a very large middle cerebral artery stroke. This one is quite new, and how do we know that? Well, we can see the mass effect. We have shifting contents of the brain. We have some cingulate gyrus herniation here. This left lateral ventricle is pushed onto the right side of the brain. Okay, in an older MCA stroke, notice it's darker. So over time, this sort of just becomes a fluid-filled space. And notice it's very similar in signal characteristics to the lateral ventricle. It's very dark, whereas in an acute setting, not so much. Okay, we don't need the arrows here, do we? But this is a large right middle cerebral artery stroke, and on an MR angiogram, we can see stenosis here of the right middle cerebral artery. Now, the anterior cerebral artery supplies most of the medial hemisphere, and so the paracentral lobule back here, remember, is motor and sensory for the opposite leg and also the bladder. So the presentation here is mainly with leg weakness and urinary incontinence, and this is a stroke that oftentimes can be confused for maybe spinal cord compression. We have mainly just one leg that's weak, urinary incontinence. So we want to keep this stroke syndrome in our minds in that patient that's presenting with leg weakness. And one clue here is to look for cognitive deficits. We talked before about this part of the frontal lobe and the anterior cingulate gyrus being very important for energizing. And so with an anterior cerebral artery stroke, we may have a patient who's abulic, kind of flat affect, very monotone voice. They don't respond quickly. They're not spontaneous. They're just kind of lying there, appear kind of apathetic. All right, so that cognitive part, and we see that especially if it's a bilateral anterior cerebral artery stroke, but you could see this just with a unilateral stroke. And we'll look for frontal lobe release signs because, this supplies so much of the frontal lobe. So they may have a glabellar sign or a palmomental reflex or a grasp reflex. Those would be kind of classic with an anterior cerebral artery stroke. All right, so here are the paired anterior cerebral arteries looping around the corpus callosum, right along with the cingulate gyrus. Now, this is a stroke that can be bilateral. So look at this. We can see it on the left and also on the right. So why does that happen? Well, let's imagine that we have a patient that has maybe diabetes, hypertension, and they've occluded this, let's say the left anterior cerebral artery. Well, if their anterior communicating artery is patent, then this right internal carotid artery can supply both anterior cerebral arteries. So the patient has no symptoms from this occlusion. Okay, but now if the patient begins to have some carotid artery disease over here, or some vascular disease of this proximal segment of the anterior cerebral artery, now they can infarct both anterior cerebral arteries. So you can imagine this kind of a thing. Now we have a patient with bilateral leg weakness and urinary incontinence. Okay, so we may be thinking cord compression, but you've got the cognitive aspects that are along with it. So that would suggest it's more likely in the brain. Now the anterocoroidal artery comes off of the internal carotid artery, and this supplies the posterior limb of the internal capsule. So there is overlapping supply here of the posterior limb. Later on we'll talk about the lenticulostriate branches. But if we have a patient who has some underlying vascular disease and then they occlude the anterocoroidal artery, then they're going to have both contralateral weakness and sensory loss from knocking out both the motor and the sensory fibers in the posterior limb of the internal capsule. And so, you might be thinking, well, could this be a middle cerebral artery stroke? Because that gives a patient weakness and sensory loss on the opposite side of the body. And so how do you tell the difference? Well, the anterocoroidal artery does supply the internal segment of the globus pallidus, but most patients with a stroke don't really have symptoms from that. The anterocoroidal artery also supplies the choroid plexus, but you're not going to have symptoms of that. And so the key finding here in an anterocoroidal artery stroke is that they usually also have a stroke involving the optic tract and especially the lateral geniculate nucleus of the thalamus. And so the distinctive pattern of visual loss with the stroke here of the lateral geniculate would tell you that it's not a middle cerebral artery stroke. So here's the lateral geniculate, and there is a posterior choroidal artery that supplies this portion, and then the anterior choroidal artery supplies here in red and in blue. And so patients with an anterior choroidal artery stroke will lose this part of their vision and this part of their vision. And so they have what we call a central beak-like sparing of preserved vision. So that is a very distinctive pattern of visual loss with an anterior choroidal artery stroke that we don't see with anything else, right? So if you find that, then you know that's what your patient has. And then the other thing that will distinguish this from a middle cerebral artery stroke is patients do not have what we call cortical findings. So cortical, what that means is, for example, an aphasia if it's left hemisphere, or a denial of illness, those features with a right hemisphere lesion. And so they lack those cortical features. All right, now posterior circulation strokes. This will pretty much all be review. When we went through the brainstem, we talked about medial medullary syndrome. So remember, off of the vertebral, we have the anterior spinal arteries, which supply the medial portion of the medulla and continue down to supply the spinal cord. And so let's just review here a little bit from our brainstem section that we have in the medulla the medullary pyramids, the medial lemniscus, and the hypoglossal nucleus. So your medial medullary syndrome involves these three structures, two pathways and a nucleus. So if you infarct the corticospinal tract, you're going to have a contralateral hemiplegia, because remember, this pathway has not crossed yet. If you infarct the medial lemniscus, then the patient will have contralateral loss of vibration and proprioception, because remember, this pathway is going the other direction. It's going up, and it is already crossed. So the deficits are on the opposite side. Okay? And if you involve the hypoglossal nucleus, then you're going to get deviation of the tongue towards the side of the lesion. Okay, and so again, just for review, if we have a left medial medullary syndrome, the patient will have a contralateral hemiplegia. Here's the corticospinal tract. Okay, here are the posterior columns, which is crossed over, and so a stroke here will give the patient contralateral loss of vibration and proprioception. And then with the left hypoglossal, you get the tongue that points towards the side of the lesion, or we could say away from the hemiplegia. All right, so a left medial medullary syndrome, the tongue points to the left, but all the motor and sensory deficits are on the opposite side of the body. And remember, that's our classic feature for any brainstem syndrome. Ipsilateral cranial nerve deficits, contralateral motor and sensory deficits. Now the pica is a very tortuous blood vessel that comes off of the vertebral here. It supplies the undersurface of the cerebellum, but most of the clinical features of occlusion of the pica or the vertebral are from involvement of the lateral medulla. All right, and so remember that lateral medullary syndrome is such a high yield question for boards, so just make sure you know this very well. So the occlusion can either be of the pica or of the vertebral artery, and I underline vertebral artery because overall vertebral artery occlusion is more common as a cause of lateral medullary syndrome. Now, if you have someone with a long history of diabetes, diabetes affects small blood vessels. And so, this may be a little more likely to be occlusion of the pica. Definitely, if we have lateral medullary syndrome in the context of trauma, now we know that has to be dissection of the vertebral artery. Okay, so we'll review what's in the lateral medulla. Well, you've got the vestibular nuclei that gives the patient vertigo, nystagmus, nausea and vomiting. Nausea and vomiting just goes along with anyone that has vertigo. The sympathetics travel through the lateral medulla, so you're going to get an ipsilateral Horner syndrome. The nucleus ambiguous involvement will give the patient dysphagia, a soft hoarse voice, dysphonia. Hiccups, which we've talked about as an important clue, and then you're going to have a decreased gag reflex on that side. Remember that patients with lateral medullary syndrome, of all patients that have had a stroke, are about at the highest risk for aspiration and developing a pneumonia. So they cannot be given anything to eat or drink, because their just swallowing mechanism is severely affected. The involvement of the inferior cerebellar peduncle and the undersurface of the cerebellum will give the patient ipsilateral ataxia. The involvement of the spinal trigeminal nucleus and tract will give the patient ipsilateral facial numbness. So these things are all ipsilateral. So the contralateral finding is from involvement of the spinothalamic tract. And so the opposite arm and leg has a loss of pain and temperature. All right, so it's really much more difficult to point out the structures that are involved in lateral medullary syndrome. So we can see the vestibular nuclei out here. All right, that gives you the nausea, vomiting, vertigo, nystagmus. Here's the inferior cerebellar peduncle. That will give a patient ipsilateral ataxia. This is from your board review handout. I chose not to label the spinal trigeminal nucleus and tract because I just think that's too nitpicky to be able to point that out. But, that's why you get the facial numbness. But the other pathways here that all kind of merge together would be the spinothalamic tract, the descending sympathetics. They would all kind of be in this location. The nucleus ambiguous, remember, is ambiguous. It's in the lateral medulla, it's somewhere in here, but, I couldn't tell you, is it here or is it here? Just know that it's in the lateral medulla. Okay, and then a picture that you're very familiar with. So again, a crossed finding. Ipsilateral cranial nerve deficits, contralateral, in this case, a sensory deficit, pain and temperature. Now here's something that we haven't talked about before. The next branch that supplies the cerebellum is the anterior inferior cerebellar artery. And this can look a lot like lateral medullary syndrome with some important differences. So we also have ipsilateral ataxia. Okay, but this is really the only stroke syndrome where you get hearing loss. Why is that? Well, the auditory pathways, as they ascend through the brainstem, cross back and forth continually. And because of all of that crossing back and forth, when you have a lesion in the brainstem, there's usually enough auditory information preserved because of all the crossings. And so we get this with an anterior inferior cerebellar artery stroke because here is the blood vessel, and off of that we have the internal auditory artery here that supplies the cochlea. Now you could have some vestibular involvement also, but I'm just going to emphasize the hearing loss. So if you have a stroke syndrome, it's kind of complicated, you're wondering what's going on, but one of the features is they can't hear in that ear, then that would be a big clue that you're dealing with an AICA stroke. This blood vessel also supplies the facial nerve, and so unlike lateral medullary syndrome, these patients may have a lower motor neuron facial weakness as well. So these two things would really be distinctive for this stroke syndrome. Okay, so remember, once we have the basilar artery, our next large branch off of that is the anterior inferior cerebellar artery, here and here. And we can see that this blood vessel right here goes right out next to the facial nerve. So remember that relationship. All right, and then the next blood vessel that supplies the cerebellum is the superior cerebellar artery. And so with all of these strokes, whether it's pica, AICA, or superior cerebellar artery, anytime you disrupt the cerebellum, there's going to be some vertigo acutely. This is less intense, and the reason is the lower strokes of the pica and AICA supply the vestibular nuclei, so you get more dramatic vertigo. That's less intense with a superior cerebellar artery stroke. Okay, but they have ipsilateral ataxia and gait ataxia, but both lateral medullary syndrome and AICA stroke is going to have that as well, so that's not a distinguishing feature. So a distinguishing feature of this stroke syndrome is they have an ipsilateral tremor, and it's often quite pronounced. Okay, so unlike all of the other types of tremor we talked about in the movement disorder lecture, this comes on abruptly, right? So that should make you think more likely of a stroke. And the anatomy of this is the superior cerebellar artery supplies the dentate nucleus and also the superior cerebellar peduncle. So when we disrupt those areas, it is more likely to result in a tremor. Now, what if we occlude the basilar artery? Well, we've already talked about locked-in syndrome, right, where we have a large pontine stroke, but you spare enough of the reticular activating system back here that the patient is still awake and aware of what's going on. Recall that the pons is very important for horizontal eye movements. And so they're not going to have horizontal eye movements, but the midbrain allows you to look up and down. So these patients have intact ability to look up and down, and that's how you can communicate with the patient, right? They can't move because the corticospinal tract is knocked out. They can't speak because the corticobulbar tract is knocked out, but they can look up and down. So you can ask them to look up 3 times, and that's how you can confirm that they're really aware and they are in a locked-in state. Now, if a patient has a brainstem stroke, they are quite likely to have double vision. And so that's just kind of an important take-home point. The brainstem is important for keeping the eyes tracking together. That's called conjugate gaze. So if we have a brainstem stroke, the eyes may not line up perfectly, so they may have a disconjugate gaze. The patient may have an internuclear ophthalmoplegia, just like we talked about with multiple sclerosis. So if someone has an INO and they're a 75-year-old patient with hypertension, diabetes, don't choose multiple sclerosis. That patient had a stroke involving the medial longitudinal fasciculus. All right, so all of this, double vision, disconjugate gaze, internuclear ophthalmoplegia, this can only happen with lesions in the brainstem. You do not get double vision with lesions above the brainstem. So notice we didn't talk about that as occurring with an MCA stroke, a PCA stroke, and all of that. So double vision in a stroke setting should always point you to the brainstem. Now, I'm not going to review the anatomy of the cerebellum again, but here I just wanted to point out that, we have these 3 cerebellar peduncles. We have lots of pathways that are important for the cerebellum that travel through the brainstem. And so when someone has a brainstem stroke, they frequently have ataxia. So you don't want to associate ataxia as something that only happens with lesions of the cerebellum, right? If we have a lesion, let's say here in the pons, well, that could disrupt this cortico-pontocerebellar tract and give the patient ataxia. Okay, so when someone has ataxia acutely, at least it does tell us the problem is in the posterior fossa. The problem is either in the brainstem or in the cerebellum. Okay, remember the Millard-Gubler syndrome. The name is not important, but you need to be able to localize it. So if we have a stroke in the pons, so that's basilar artery distribution, the patient may have a contralateral hemiplegia and an ipsilateral sixth and a seventh nerve palsy. Okay, so remember the seventh nerve wraps around six. They're very close together. So here's the seventh nerve, here's the sixth nerve, and the seventh nerve loops all the way around. Okay, so if we have a stroke right, in this location, like half of the pons, the patient will have an ipsilateral sixth and a seventh nerve palsy, and here's the cortical spinal tract. So they may have a contralateral hemiplegia. And yeah, they could have contralateral sensory loss as well, but we can't learn everything for every stroke syndrome. Recall that with a pontine stroke, we may have a gaze palsy, where the eyes now look at the hemiplegia. All right, so if we have a right pontine stroke, we're going to have a left hemiplegia. Okay, what does the right pons want to do with respect to the eyes? It wants to move your eyes to the right via the sixth nerve and via the pathway that goes through the MLF to the opposite medial rectus. So if we lose that normal tone, trying to pull the eyes to the right, then the normal PPRF6 over here, which is not drawn, is now overactive, and the eyes get pulled to the left. So they look at the hemiplegia. All right, so we've been over the pica, the aica, the basilar artery syndromes, the superior cerebellar artery, okay, and now we have the posterior cerebral artery up here. So remember that, where's the midbrain? Well, you'd have to put your finger into this space here, and then you would deep down touch the midbrain. So the posterior cerebral artery does lie right on the midbrain and supplies most of the midbrain. There are also branches off of the superior cerebellar artery that go back to supply the midbrain, but posterior cerebral is the most important. And so our midbrain stroke that we've already talked about in the lecture on the midbrain was Weber's syndrome. So remember there we get an ipsilateral third nerve palsy and a contralateral hemiplegia. And so the lesion here is third nerve cerebral peduncle. Now, more commonly, when the posterior cerebral artery occludes, we see the stroke in the more distal vascular territory, where it supplies the occipital lobe. So patients present with a contralateral homonymous hemianopsia, and recall that for boards, it's very often they're driving into things on the opposite side. And the slam dunk, if you just see the words macular sparing, then you know it's a posterior cerebral artery stroke. So the posterior cerebral artery on its way back to the occipital lobe does supply the undersurface of the temporal lobe, so we can have some memory deficits. Okay, but really there isn't much else. They don't have a hemiplegia, they don't have an aphasia, so it's mainly this visual field deficit. And if our occlusion is very proximal, like right where the posterior cerebral artery comes off of the basilar artery, then the patient may also have a Weber's syndrome with the third nerve palsy and a contralateral hemiplegia. But usually we don't see these two together, although it's theoretically possible. I don't think I've ever seen that. All right, so just remember the posterior cerebral artery comes around the third nerve here, supplies the undersurface of the temporal lobe on its way back to supply the occipital lobe. All right, and here is the posterior cerebral artery vascular territory. Okay, and on the medial section, you can see how much of the occipital lobe it supplies. So you need to be able to recognize a posterior cerebral artery stroke. So here's a left posterior cerebral artery stroke. And remember that that's the one where you can see this alexia without agraphia. And so very important you remember this. So here we have a left PCA stroke. And so I should have pointed out that the posterior cerebral artery also supplies the splenium of the corpus callosum. So with a left PCA stroke, the patient is going to have a right homonymous hemianopsia, or hemianopia, same thing. Now, I didn't draw this with macular sparing just because that's a favorite board question, but in the real world, we are more likely going to have something that looks just like this. And so these patients cannot read because you don't read with the occipital lobe. They get the words back here, but to interpret them, you need to move it over to Wernicke's area. And so they can't do that. So they have alexia. But remember, agraphia, the ability to write things down, is not dependent on vision. So if we give a patient an auditory command to write something down, they're going to understand that in Wernicke's area. You could do this with your eyes closed, and then move that forward to Broca's area here in the left hemisphere to move your right hand to write down the words. But then they can't read what they just wrote, because reading requires an intact connection between the right occipital lobe and Wernicke's area. Now, if we have an occlusion of the basilar artery, we may have then a stroke in both posterior cerebral artery vascular territories. So obviously a patient would be very devastated by this. So they would be blind, but the lesion is really bilateral occipital lobes. And so especially from the right hemisphere involvement with this, the patient may have denial of blindness. And so we call that Anton's syndrome. And so my experience with these patients is we usually need to restrain them, keep them in bed, because they don't think they're blind and they get up and want to walk around and go to the bathroom and they can injure themselves. All right. Next, let's go over the small vessel stroke syndromes, or the lacunar strokes. And so these are subcortical strokes that are less than 2 centimeters, and they're due to involvement of the small penetrating arteries. And so diabetes, a major risk factor for these because of its involvement on the small blood vessels. All the other risk factors, dyslipidemia, hypertension, certainly contribute, smoking, and so on. So how do we diagnose these? Well, patients, 2 things. They have one isolated deficit. Okay, so there's just one thing going on, not all of the 5 or 6 things like we talked about with some of the other stroke syndromes, and they have an absence of large vessel symptoms. So for example, with middle cerebral artery, it's aphasia or denial of illness. With anterior cerebral artery, they also have all of the frontal lobe cognitive aspect. So we don't see that with lacunar strokes. Right? So these would be just some example here of large vessel symptoms. So the most common, and I think almost every student that goes through the neurology clerkship will see this, and it is the most common stroke of all, is a pure motor stroke. And so this is due to occlusion of the lenticulostriate artery, which supplies the motor fibers in the posterior limb of the internal capsule. Okay, and it also does supply the genius, so you get the cortico-bulbar tract as well. So remember, the lenticulostriates come off of the middle cerebral artery, so it's part of the anterior circulation. So the stroke is not very large, all right, but it affects a critical area. So here are the lenticulostriates branches supplying the posterior limb of the internal capsule. So remember, in the posterior limb, you have the corticospinal tract and the superior thalamic radiations. These, however, this is all ascending sensation from the face, arm, and leg. And this is not supplied by the lenticulostriate branches. It supplies the corticospinal tract and the corticobulbar tract. So that's why in a pure motor stroke, patients have a contralateral hemiplegia, and it also does involve the face. But sensation is normal. That is the key thing. We have normal sensation. It's pure motor. That's why we call it pure motor. So if we see a pure motor hemiplegia, the lesion has to be right here, and you can confidently say that it is the lenticulostriate artery that's affected. A pure sensory stroke is now posterior circulation, and the infarction is usually in the thalamus. And so from involvement of the VPL, that gives you the opposite arm and leg has a loss of sensation. VPM is for the face. And so patients that come in with pure acute sensory loss on one side of the body, then almost certainly they have had a thalamic stroke. So remember, pure motor is anterior circulation, pure sensory is posterior circulation. And so the branch here is the thalamogeniculate that comes off of the posterior cerebral artery. All right, so the thalamogeniculate, pure sensory, usually the stroke is in the thalamus, although sometimes it can also be here in the posterior limb, but that would be a lot less common. And here's a normal MRI, but we can make out the posterior limb very nicely. So we have a very sensitive test to detect even small ischemia. All right, and something I think we've covered quite redundantly, but it's another lacunar stroke syndrome, is hemiballismus, where we have a stroke that involves the lateral geniculate. So they have wild shaking movements on the opposite side of the body. So notice with all three of these lacunar stroke syndromes, there is one deficit. So it's pure hemiplegia, or pure hemisensory loss, or hemiballismus, not five things like we saw with all of the other conditions. Now, unfortunately, occasionally, patients that have a lacunar stroke, probably from some swelling around the stroke, so it involves surrounding areas, you can have kind of mixed motor and sensory deficits on the opposite side of the body. Okay, but let's just say we had someone that presented with a right hemiplegia and hemisensory loss. Well, if that were MCA stroke, you'd be expecting an aphasia, a visual field deficit, a whole bunch of other things. So, this is a little one exception to what I said. It's one fixed deficit. Here there are two. If someone has had a bunch of lacunar strokes, you eventually involve so much of the corticobulbar tract that patients have a pseudobulbar palsy. And so now we can go over all the things we've talked about in class that can cause pseudobulbar palsy. One is where patients have had lots of subcortical strokes. And so remember, if you have just lots of subcortical strokes, eventually you're going to affect the critical pathway. And so a patient will have a hemiplegia or something like that. And when you disrupt that much neuroanatomy, there's going to be some dementia, right? So it's multi-infarct dementia. The pathway you want to associate with pseudobulbar palsy is the corticobulbar tract. So here are the things that can cause pseudobulbar palsy. This first one we don't see so much anymore, but if you have just a really bad case of multiple sclerosis with a lot of demyelination of the corticobulbar tract, you could have pseudobulbar palsy. So that would be a young individual. ALS, remember you have degeneration of upper motor neurons like the corticobulbar tract. So now we have a patient with upper and lower motor neuron findings. Remember our two conditions that sort of look like Parkinson's disease but aren't, progressive supranuclear palsy and multisystem atrophy. Those patients have pseudobulbar palsy. And then in this lecture, multiple subcortical strokes. So now we've got an old vasculopathic patient, older, that has pseudobulbar palsy. So all of the different causes have quite unique, different features, different presentations. Now, if we have a patient that has an episode of very low blood pressure, like someone has a cardiac arrest and they're getting CPR, then they're more likely to have the watershed areas of the brain affected. So there is a watershed area in the brain between the anterior cerebral artery and the middle cerebral artery right here. There is a watershed area just in the vascular territory of the middle cerebral artery itself, right here. And there's a watershed area between the MCA and the PCA back here. And so this is kind of the vulnerable area in our hypotensive stroke. And so here's an MRI scan. If you see this, you'd want to be going, the right answer is a hypotensive event. And so the unique feature in these patients is, the key thing is to just be aware of the homunculus. That notice in this territory right here that we've got the hip and the shoulder right in this location. So the proximal muscles for both the arms and legs are affected in these patients. So usually the story for something like this is a patient that had a cardiac arrest, they're intubated in a coma for a while, and then they begin to recover. And as they recover, they're noted to be weak, but they're weak in proximal muscles. And so this is called a man in a barrel syndrome, or I guess now a person in the barrel syndrome, where when they're coming out of their coma, they've got good hand and feet, distal strength, but they can't lift their arms up off the bed. They can't lift their leg up off the bed. And so you might be thinking, well, this kind of looks like a muscle disease. It's proximal muscle weakness. But of course, this is in the setting of someone that just had a cardiac arrest. So very different, than like an inflammatory myopathy or something like that. And of course, you're going to affect upper motor neurons here, so you're going to have upper motor neuron findings in a patient with a stroke like this. Now finally, and you can just relax with this part because I won't ask you any management issues for stroke, but I can't go through this lecture without telling you something about what we can do for these patients. And so for many years now, we've had TPA, or alteplase, as a so-called clot-busting medication. So it triggers local fibrinolysis, and the key thing here is this needs to be given to be beneficial, ideally within 3 hours. We can give it up to 4.5 hours. So it loses its effectiveness the longer into the stroke without giving it. And so that's why hospitals now have this stroke protocol that we can very quickly get everything necessary done in an expedited manner so we can give the patient the TPA as soon as possible. So if we need to know, though, when the patient was last normal. So if someone goes to bed at 10 o'clock in the evening and they wake up at 6 in the morning and they can't move the right side of their body, that patient is not a TPA candidate because we don't know, did the stroke happen at 11 at night or did it happen 30 minutes before they woke up? And the reason we can't give TPA in that setting is because when you give TPA to someone that's had a stroke, there is a risk of creating bleeding into the stroke. And so, this is not just a benign kind of a thing. So we have to give it in that time window. Now, if someone has a large vessel stroke in an anterior circulation, like an MCA, then we can do a thrombectomy within 24 hours of the onset of the stroke. And so there are a variety of devices that can go in, can actually extract the clot. Okay, and so again, that's a 24-hour time window. Something else that we do for patients after a stroke, when someone has a stroke, their blood pressure always goes up. And that is just the brain's attempt to get more blood flow, more oxygen to the area of ischemia. You do not want to interfere with that. And so we rarely treat high blood pressure in patients that have had a stroke. We just let the blood pressure run high for 24 hours. That is called permissive hypertension. Okay, and then after 24 hours, we'll begin to bring it down. Now, obviously, there is a range for this, which you don't need to know about for now, but if it goes too high, then we may give them something gentle to lower it just a little bit. And when someone has had a stroke, this should be a wake-up call. Well, it's time to do something about diet and exercise, stop smoking, and so on. Now, in terms of stroke prevention, we use aspirin as our first line for non-cardioembolic strokes. Okay, and overall, that will lower your chance of having a stroke by about 20-25%. Warfarin, or Coumadin, is used for the cardioembolic strokes, like prevention, like someone that has atrial fibrillation. And in the last 10 years or so, we have these NOAC agents, non-vitamin K antagonist oral anticoagulants, which are really a nice alternative to warfarin. Now, if someone has a stroke in an anterior circulation distribution, like an MCA, ACA, and if they've got a carotid narrowing that's more than 70%, then they probably are a good candidate for a carotid endarterectomy. So again, vascular surgery can be really helpful for these patients. They need to be symptomatic. So if someone has a 70% narrowing, but they've never had a stroke and never had any symptoms of it, then we would manage that medically rather than referring them for surgery. All right, here's a patient that I saw a few years ago. Was actually visiting a patient at the VA and collapsed and had a hemiplegia, so it was obviously, she'd had a stroke. And I was sent the picture of this. This was a thrombectomy that the patient had, a large clot that was going into the middle cerebral artery.